It is the top of the hour, so let's go ahead and get started. Good morning, everyone. I am Anne-Claire France with the CARE Collaboratory, and welcome to the CARE Collaboratory's inaugural conversation on a series around creating a new and better normal. Today's topic is the role of human-centered design in the post-pandemic healthcare ecosystem. We do have a couple of housekeeping items, and that is we will have time at the end of the conversation for questions and comments. And so please use the chat function during the conversation to write your questions and or comments. And also we are going to be sending a very brief evaluation to each of the attendees so that you can let us know how we can improve these sessions and also what you thought went well. And finally, we are recording this session, so if you're not speaking, please have your microphone on mute. And we will be posting that recording on the CARE Collaboratory website in the very near future. So any of you, who would like to share this and let other people know about it, then it will be available. So let's start with a very brief introduction to human-centered design. Put simply, it's a framework that puts the human firmly at the center of problem solving. And solutions are developed by involving the human perspective in all steps of the problem-solving process. Human involvement typically takes place in observing the problem within context, brainstorming, conceptualizing, developing, and implementing the solution. It aims to make systems usable and useful by focusing on the users, taking into account that humans are animate beings with feelings and emotions, and factoring this into the design to meet their needs and requirements. So we have 4 panelists this morning representing 3 different perspectives joining us today, and let's begin with each of them giving what we're calling the one breath introduction. So Chuck, would you mind going first?
Sure. Good morning, everyone. My name is Chuck Stokes. I am a founding partner with Relia Healthcare Advisors and a recently retired healthcare executive after 40 years. I started my career as a critical care nurse.
Great. Thank you, Chuck. And Reid?
Good morning, everyone, and welcome. My name is Reid Pierce, and I am an internal medicine physician. I practice as a hospitalist currently and lead a group of hospitalists at Dell Medical School at the University of Texas at Austin. And I've done a lot of care systems redesign and has woven into that work design thinking as a practice, which is a great deal of fun for me.
Great. Jeff?
My name is Jeff Eyet. I'm a tutor to a first grader, and I moonlight as a professional, both teaching at Berkeley and co-founding the Berkeley Innovation Group with my colleague, Kellogg.
Great. And Clark?
Good morning, everyone. I am a professor at the University of California at Berkeley in the design thinking curriculum of the Haas Business School. I am, as Jeff mentioned, a co-founder with him in the Berkeley Innovation Group, and like him, my grandchildren are the object of my tutoring.
Wonderful. Thank you all. So we put together a few questions for our panelists, and the first one we have is around really creating great places to work for our workforces. So, however, in many industries, the financial pressures from COVID-19 has reinforced a cycle of putting profitability first, then taking care of the customer, then taking care of the workforce last. Despite this trend, how can organizations, while in pursuit of great performance, find ways to be great places to work? Reid, can we start with you?
Thanks, Anne-Claire. So this paradox you described, I think, is particularly poignant right now as the financial pressure on so many organizations feels extraordinarily high. And, when I first got introduced to leadership and management as a set of principles and skills, one of the key themes I was introduced to is this idea of financial stewardship, that money and financial performance is the lifeblood of an organization. If you don't take good care of that, then of course you can't provide services to people, and of course you can't hire and take care of the workforce. And that logic, I think, has a lot of both history and natural appeal to it. And as we think about these ideas of putting the human being at the center, using human-centered design principles to accomplish our goals, to create high-performance teams and organizations, one of the really counterintuitive and I think powerful insights that comes out of this work is the fact that the beating heart of our ability to accomplish work is actually the people who are doing the work. And inside those people is energy. Inside those people is a whole host of insights and commitments and ideas. And if you can engage that energy and those insights, and you can bring those to bear on the questions of how do we take care of a population of patients in the healthcare setting, or how do we take care of a population of students in education, you actually get this amazing opportunity to do good work, to work on the most important problems, to bring creativity to how we approach the things that are in front of us. And you provide a great service, a contribution to society, and the business tends to take care of itself. And it probably took me 10 years to come to that realization. And I think in clinical medicine, that is a particularly important idea to hold on to in this time, because the people in healthcare who are going to make this right, who are going to figure out new models and systems and are going to provide great care and healing to patients and families, are not, they're not Excel spreadsheets that define numbers and financial performance. They're human beings sitting with patients and families doing that work, modeling and reforming the systems. And I know that Chuck, Jeff, and Clark have a lot of interesting thoughts on this question as well.
All right, great. Thank you, Reid. So Jeff, how about you? What is your thoughts?
Thanks. I read that article in the Wall Street Journal yesterday talking about how banner healthcare's drive to profitability put them in a difficult position when COVID hit. And it was, I think, again, I understand their motives in terms of profitability. As Reid said, that is the lifeblood of any organization. And throughout that journey, what really made them successful was, and I think one part that the article didn't highlight is they highlighted bringing in, hiring nurses from other states to come in and work. And I think the piece they didn't discuss in the article, what I'd love to understand better, is how did the existing nurses at Banner, obviously they work extra shifts, but how do they incorporate providers from other departments within their facility, but also providers that were hired to come in and just handle the surge capacity. And I think that's the real key. So it's very easy to point fingers at the large organizations, but at the end of the day, the people who make it successful are the individual providers. And how are we looking out for their emotional well-being is really what attracts the design element that attracts me to this question.
Great, thank you. Clark?
Well, at the heart of this question, just to add a little bit to what others have said, the heart of this question is the phrase great places to work. And when you think about the great places that you have worked, they tend to have some things in common. And primarily it is you were listened to and your opinion mattered. And if we simply take that paradigm and lay it on top of any organization, but the healthcare organizations we're talking about, it's odd to me that you suddenly have a radically different organization, because as we spoke about the other day, this is only common sense, but it's very rare. So what is possible? What is the challenge we can take up to bring listening and caring to our workplaces? And I believe that is the single most powerful change that we can make to improve not only the working conditions, but the health outcomes and the patient experience. If we get that right, the economics take care of themselves.
Great, thank you. Chuck?
Sure. I've been in this business for 40 years, and financials have always been kind of at the priority list for most executives and governance structures throughout healthcare. But sometimes I think we use the financials as an excuse as to why we can't do certain things for our workforce, and we have to get beyond that. And a recent Gallup poll this past year said that only 37% of the workforce is actively engaged in their work. And so when you think about that, 37%, the lost productivity on the other portion of the workforce, it's really a really staggering concept to kind of contemplate. And from my standpoint, I think that employee engagement, if you're going to be a financially successful organization, engagement is at the top priority list. And so I've had a lot of experience with Baldrige organizations, and in the Baldrige organizations, there's kind of a formula for success. And it goes like, if you have engaged employees and physicians delivering an exemplary, high quality, safe care to their patients with an exemplary patient care experience, you don't worry about the financials. They will take care of themselves, and you'll have the opportunity to reinvest in the organization. And so I think that we have to figure out, even prior to the pandemic, engagement was a real big issue. And I think post-pandemic, it's going to continue to be a bigger issue because of employee burnout, and people are just worn out. And I think that what we're looking for in healthcare is we're looking for transformational change. We're not looking for incremental change. And if you don't have engaged employees and physicians doing that work, it's going to be infinitely more difficult to be financially sustainable going forward. And I think Clark made a point, is what people want, what employees want, is they want their opinions heard. And so really kind of embracing the concept of diversity and inclusion and really listening to the employees is the best way to really drive transformational change instead of what I refer to as the incremental tinkering.
Thank you, Chuck. So I'd like to open it up to all four panelists. So anyone, Jeff, Clark, Reid, and Chuck, would you like to follow up with any additional commentary?
One thing I would put out, Anne Claire, as we talk about this principle of putting human beings at the center and allowing things like human emotion and human insight to really be the drivers of engagement and the transformational change that Chuck was referencing. There is a set of fears and beliefs that I think are important to name. So you've got to be willing to trust the human beings who show up to do the work every day, that they're going to do the right work. And you've got to be willing to engage with the natural messiness of the emotional journey that human beings bring, which I see as this tremendous source of human connection, power, and authenticity in the work we do. But a lot of the management models I think we've inherited from the 20th century do exactly the opposite. They say, please check emotion at the door, be a professional. You can't let people have too much free range because management has the good ideas and needs to hold people accountable. And so this is really a transformational set of ideas in terms of how we engage with our people. And so, trust and freedom and willingness to engage with the emotional side of what we're doing every day become part of the work. And that's not easy for organizations to do because we haven't really thought or practiced in these ways for a long time.
Yeah, absolutely. Absolutely. Clark, how about you? I see you nodding.
Well, I'm only nodding. Thank you. I'm only nodding in agreement with Reid that this issue of trust is so big, and the processes by which we build organizational trust are, of course, complicated, but it in the larger picture, it's the ROI on the investment of listening and trusting and building those strong connections is immensely more valuable than the ROI on an invested $1 billion in new technology.
Mm-hmm. 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 Well, I have a follow-up question to the group. Where do we see the leaders in this trend that we've been just talking about now in terms of what they're experiencing? I mean, they're sort of even from senior management throughout all levels of leadership, they are people too. And having during these extraordinary times. And so Chuck, can I ask you to make some comments about that?
Sure. I think that leaders, what they want to really do is they want to solve problems when organizational problems present themselves. But I think that one of the things that leadership has to do in the area of trust is learn to trust their physicians and their employees, because the executive office will never have the perspective that the frontline physician and the employees have about problem solving in the organization. And that takes an extraordinary amount of trust for the senior leaders to say, I'm going to put together, again, a human resource group of my best and brightest clinicians and middle managers and leaders in the organization. And I'm going to trust them to help solve these problems. And I think that, again, it's kind of back to the truly embracing the issue, the concept of diversity and inclusion. We give a lot of lip service to it in organizations, but we don't fully embrace it. And these kind of initiatives really have to be led from the CEO or at a minimum the COO, because they can't just be pushed off to another person as their job. The organization has to see the top person embracing that, and that sends a lot of trust messages to the rest of the organization.
Mm-hmm. Mm-hmm. Jeff and Clark, what specific things about human-centered design would be applicable to leaders during this time? I know that you all work with leaders in just this very thing.
That's a great question. I think a classic example is Clark and I were consulting for a traditional company in an established industry, in the waste management industry, right? Very established industry. And the CEO was separated from the person who interacted directly with the customer by 6 layers of management. So there's probably highly unlikely that very innovative ideas are going to make it all the way to the top. And so exactly to Chuck's point, we need to understand what's happening at the root level. The second piece I would add to that is just a comment Clark and I heard the other day. We're working with a technology company and talking to their DE&I team, and their perspective is unique in that as AI comes into technology, it's going to automate the most basic roles, and it's those lower level roles where organizations typically see their greatest diversity. So by bringing that automation, we're going to reduce our diversity, and then once we reduce our diversity, we still have the traditional management structures on top of it, blocking that information from reaching the top. So I think we're actually pushing ourselves a little bit further away from those front lines and bringing them closer. And that's a trend I think Clark and I are very passionate about reversing.
Mm-hmm.
To build on something that Jeff said, and also something Chuck said the other day in our pre-call, the people who are running the organizations tend to be they look a lot like me, both in gender and skin tone and age. And the point was made that I'll be the poster child for that person, are somewhat risk averse. We don't really want to change much. We're just trying to get out the door with things intact and not destroy the organization. Now, I'm stereotyping, aren't I? And I know that. But the tendency of that persona is to be risk averse, to just keep the trains running and not take on the important big challenges that we are now talking about. And I think that's a dilemma. If you're a leader that has what you want and you're just keeping the chair warm, you are not going to take on anything as dynamic as transformational change. I don't have the answer to that. I just, Jeff and I, we are different ages, and we talk about this a fair amount. And I think it's widespread in leadership of healthcare organizations.
Mm-hmm. Mm-hmm. Reid, do you have any follow-up comment from your perspective?
I think the only other thing I would add, Anne Claire, is that the pursuit of user or human-centered design starts with a different set of questions than we have traditionally started with when trying to analyze a problem in our big organizations. And so some of this is about leadership, some of it's about history and culture, some of it's about the structure and the habits, the organizational habits we've developed. But some of it's about a new approach to inquiry that I think we're learning. And so, we've seen some insights into that movement. So an example, I think, in the last 10 or 15 years that points in this direction of new forms of inquiry is, for example, to say, you know, what if for every quality improvement project we run in a healthcare delivery organization, we actually invite a patient or family member to be a full contributor on that QI initiative? Not somebody you call 3 times to sort of check the solution, but someone who is helping drive the change. The user, the recipient of care, is actually part of the redesign team. That's not something we thought to even ask 10 years ago. And so I think learning these new forms of inquiry about how we ask and answer the key questions that lead to transformational ideas is part of what we've got to work on as well.
Yeah, excellent. Thank you. I want to remind everyone that we're going to be having, opening it up the conversation with about 15 minutes to spare at the end of the session. So please use the chat function at this time for any questions and comments that occur to you, and we'll be monitoring that and then look at them for the panel to address in just a few minutes. So just a little reminder on that. So let's go on to the next topic we have, and the question is, COVID-19 has put significant strain on the nation's social safety net. Many individuals and families are finding themselves interacting with health and human services agencies for the first time ever. So how can these agencies shift their thinking, putting the focus on the experience that they are delivering to the people they serve while targeting the limited resources to areas where they can have the greatest impact? So Chuck, why don't we start with you?
Sure. Well, we've all worked with a lot of different social agencies through our careers, and certainly with COVID-19, the relationship between healthcare organization and these social agencies, we've tried to bridge gaps that we've really not bridged before. And so I think that some of the things that social agencies are going to have to do, just like healthcare organizations, is they're going to have to rethink their mission, vision, and values. And I think that a lot of times organizations, even though they're there to do good for the community and the public, their mission, vision, values get stale. And so a lot of these agencies, just like healthcare, are going to have to reinvent themselves over time. And I think that one of the things that the pandemic has pointed out is there's always been kind of mutual cooperation between agencies and healthcare organizations, but there's not been real collaboration. And I think that going forward, you're going to have to move that cooperation to a more collaborative environment. And we're really going to have to use data and become data-driven to make sure the agencies and the organizations really understand what their constituency needs really are. And you know, my comment about data-driven is, in the absence of data, any opinion will do. And so I think that you just we have to get more data-driven about that. And I think that there's some new partnerships that could emerge in this post-pandemic environment. One, it's pointed out that we've not invested in public health in this country, and the relationship between healthcare industry and public health has not been very good. So the opportunity exists for us to take social agencies, public health, and the for-profit and not-for-profit healthcare industry to say, how can we come together and truly collaborate to come up with some new models to deal with the social with the social disparities that we're dealing with today? Because many of these things are not old to us in healthcare. The fact that there's a disproportionate share of African Americans and Latinos dying at a disproportionate rate is like, we've been talking about that for 20 years. And it's like, we just don't get to the root cause of the problem because we're cooperating, but we're really not collaborating.
Yeah, thank you. Reid, how about you?
So one of the things, and I'll take a clinical perspective here, and Claire, that's been really interesting is I think these gaps that Chuck was alluding to, which have always been there, have really become so much more visible through the COVID-19 pandemic. And part of what I mean by that is, hospitals and to a degree clinics really geared up to do rescue care, to take care of people who were very sick. And yet there were, all of these things that could and should and needed to happen outside of the care delivery system in response to the pandemic. And we were not able to organize ourselves in a truly collaborative fashion. And, when you think about the experience that patients and families have, I think we've designed around the wrong thing. So we've said, if you have this list of issues, come to the emergency room, and if you need to, we'll admit you to the hospital. But if you have this list of issues, we got to send you somewhere else. The experience of patients and families is, I go through this journey that starts with, I'm concerned about COVID, and now I think I might have COVID, and maybe I do have COVID, and how are you going to take care of me physically, but then emotionally, economically, in terms of keeping my family safe, accessing all the parts of my life that I need and want to get back on my feet. That's the journey. And we have to find a way to design around that entire journey. And that involves pieces that Chuck was talking about. This isn't just healthcare delivery. It's also public health. It's also education, and it's economic policy, and it's a bunch of these structural issues that we've put in silos. And, this keeps coming up again and again as we're trying to take good care of people who have COVID-19. And I think it's an extraordinary opportunity to embrace this idea of looking at the entire sort of cycle of human experience around this disease, not just the care cycle of the disease, and to say, how do we build better network systems and collaboration to meet needs all along that journey?
Yeah, thank you. Thank you. Clark, how about you?
Thank you, Anne Claire. I'm going to build a bit on what Reid and Chuck have said, and hopefully it's not duplicative. But what the pandemic forced us to do was change our point of view, even if it was only momentarily, because we generally operate in an inside-out point of view. We're inside our own individual silos, and we're looking out to the other collaborating or cooperating organizations. But what COVID did was force a point of view change. So we were focusing on patients first. And lots of other people in the delivery system have suffered from that because we have such burnout and such intensity. But what it did give us was a momentary glimpse into how it might want to be. By focusing outside in instead of inside out, we do see the issues differently. And I think that is, as Chuck mentioned, not over the arc of decades of doing this work, noticing these phenomena, we need to change our point of view around what the systems are designed to deliver. And the best way to do that, harking back to the human-centered design piece, is to do it from an outside-in perspective, that is the user journey. And when we do that, we find all of the things that stop making sense in the system, i.e., you go to the ER and you're triaged and sent into one of the pathways through the healthcare system. And there must be a better way to do that. And I think COVID has given us some insight into some of the better ways we can start to build or rebuild institutions around to save money and save lives.
Mm-hmm. Mm-hmm. Yeah, yeah. Jeff?
Yeah, the tactic for people on the phone who are on the line who are thinking about tactics to use to begin to explore this. I would just encourage you to take 8 Post-it notes and write down the 8 most important steps your user takes before they see their doctor. So I'm not going to the ER. I just pretend it's normal times. I have an ear infection or my ear hurts and I have a history of ear infection, so I go see my primary care doctor. What are the 8 most important things that they do? And what that forces you to do is it forces you to understand what are the most important things. But when you start at the beginning, you typically run out of Post-it notes. And so what we encourage folks to do is start at the end state and define that first. And so the first Post-it note that I would write is, feeling comfortable and open in front of my doctor. And if we put that down and then we design from my ear hurts to feeling comfortable and open in front of my doctor, that's going to reimagine the journey. And the reason why I say that is I'm going to be Clark and I are running a design sprint with a hospital in Pennsylvania, and I was framing in the opportunity with their innovation team. And the conversation started when I asked, well, who are the people that come into your hospital? Oh, emergency, ambulatory, inpatient. And I said, well, which one of those is the grandmother? And they looked at me like I had three heads. And it was because they were again, just looking at the world through their lens. And how do people arrive in their door? And if we took the time to understand where we want our patients to be and design for that, and understanding that a grandmother may have a different journey than a single mother, than an undocumented worker who got hurt on the job site, etc. So that's my kind of tactical answer as to how we can begin to take design and apply it to what we do in healthcare space.
Mm-hmm. Mm-hmm. I have a Post-it story myself. A couple of years ago, I was asked by a large healthcare organization to really map out where that particular organization had presence in the lifespan, if you will, of patients and their process of going through the healthcare system. And so we realized that certainly the lifespan, if you will, or the process begins way before anybody hits the door, way before. And so, and all our Post-it notes were in the walls, inside the walls. And it was a real wake-up call that, we're not even coming close to addressing the needs of the humans who are looking to us to provide for a healthier community. And so that got started a lot of some of these conversations in this different point of view that you all have been talking about. So any follow-up conversation on that from Chuck or Reid or Clark or Jeff? Any of you want to have any follow-up to this particular topic before we move on? I'm sorry, what'd you say, Jeff?
Oh, I just said thanks for sharing.
Oh, you're welcome. You're welcome. Let's just say the chief quality officer was shocked when she saw where all the Post-its were. She's like, "Oh my, we have some work to do." We're like, "Yes, isn't it great how a picture is worth so much?" To see that. So I love Post-its. It has changed our lives. All right. Moving on. It's been demonstrated with identification, treatment, and prevention of COVID-19 that healthcare can move fast to determine better ways and deploy rapidly. How can we retain some of that speed and other challenges in healthcare without the urgency of a pandemic? And so really what everyone has noticed, and anyone who has been in healthcare for a long time has known that change often takes a long time to implement because it has to go through the various iterations of stakeholders and all those kinds of things that is all very robust and good. But what COVID-19 has allowed to happen is some change that one would have thought in previous times would have taken a long time can happen very quickly, such as, let's try this treatment, let's do this, let's do that. So that is one good thing that has come out of this sort of a serendipitous good thing that's come out of this, and that it is possible to make good, robust changes more quickly. And so I imagine, or everyone else is probably thinking, we did it before, why can't we keep that up when it comes to other types of things in healthcare to really create this healthcare ecosystem? So Clark, we'll start with you on your thoughts about that.
When the house is on fire, you move quickly. and when the flames are out, you slow down. And that analogy is, I'm trying to draw that toward the response to COVID. During times when you don't have the luxury of running things up and down the hierarchy, things get done more quickly. And for the most part, they get done well. So the question, and we are being asked, and we are asking this question not only in healthcare, but across all kinds of institutional responses to current challenges. is how can we maintain this spirit of innovation, of roll up the sleeves of can do, now that things are sort of reabsorbing back into something we might call normal. And that really is the organizational and the mindset challenge for all of us. And what we need to do is understand what was happening during the pandemic response when the house was on fire. And what was happening? Well, decision-making was at the delivery level. People were moving quickly and they were using anything they could to get results. And to illustrate that, I will talk just a moment about all of the amazing hole-in-the-wall PPP manufacturing and inventing and producing shops that were opened up instantly. At one point in April, we were in the Bay Area where I live. There were about 1,200 small little micro manufacturers 3D printing face masks all night long, all day long. And they were dropping them off at ERs and things like this. And then, of course, that began to scale up. But the unleashing of innovation when the demand is there is something that is uniquely occurring during crises. How can we continue to uniquely innovate? Well, it needs to be organized a little bit. It needs to be fueled a little bit. It needs to be seeded and funded. Mostly, in this case, it was supply chain problems. Well, we somehow innovated our way around all of that with a combination of government, institutions, and individuals. Now, it's not really sustainable over the long term to have people working all night long and all day long, taking anything they can from their personal or their collective resources to meet a challenge. But the lessons inside that activity are so profound for us. Suppressing decision-making from top to bottom to put it right on the front line of delivery, to using available resources in rational ways, to unleashing people's innate problem-solving ability and not having them to do stereotypically, to fill out the triplicate form. These are the things that we can learn from and organize innovation after this ad hoc application of unleashing innovation in people, but organize it and build the culture that allows those things to go on. It's not radically complicated. It's just radically different.
Excellent. Thank you. Jeff, do you want to follow up with that?
I appreciate what Clark had to say. The model that sticks out to me is we need to become connectors. The people who thrived during the outbreak are the people who were able to connect with others and were the people who really brought about disruptive solutions. There were very few. I would challenge anyone to point to a technical innovation that really emerged from this. There wasn't a new intervention, a new physical intervention design. There wasn't a new drug developed in this time. It was because of the urgency, we had to work with what we have. And what enables that are the connections between people. And that's not tangible. You can't calculate an ROI. You can't go to your CFO and guarantee a return for the budget that you're asking. But it is the unspoken bonds between people that really drive innovation and resourcefulness in these difficult times. And ultimately, I think if you went probably reflected on some of the greatest triumphs were people playing a bigger role than probably their job description, but ultimately, and they did it with less than what they had.
Mm-hmm. Yeah, for sure. Chuck, how about you?
Well, I think prior to COVID, many healthcare organizations we were all running around with our hair on fire. And we were trying to figure out, how do we decrease costs? How do we improve our reimbursement? How do we deliver higher quality, safer care to people? And how do we meet this now inescapable consumer demand and meet our customers' needs in a more meaningful way? And we were all doing that. We're spending money. We were talking to our boards about needing to invest more in technology than bricks and sticks. And so all of us were really going at this warp speed velocity, we felt like we were prior to COVID with these big initiatives in healthcare. And so I think that Clark alluded to it earlier, and it is about having a model in place. We've always, in healthcare, we have a tendency is when you do what you always done, you get what you always got. And if we were successful with our model, we didn't change. There was no impetus to change that model. But a lot of healthcare organizations do not have a model, an operating model in place that is a disciplined model to deal with good times and bad times. And I do think that that's one of the things that I would be encouraging organizations to do. If you didn't have, and it doesn't matter what it is, it's whatever works for you. My experience has been with Baldrige and numerous organizations, but that's not the only model. You have to have one that's right for your culture in order to build on. But I think that, one of the biggest things that I see from a leadership standpoint today is organizations have a tendency to, when they know that they have to change, and I'm going to use the financial, we started the conversation with the need for financial sustainability. Everybody gets that, and nobody faults leadership for trying to be financially sustainable. But if we're going to do that for the future, we have to be realistic about what is needed to be financially sustainable. And this is where the issue of trust and employee engagement really gets in conflict with leadership. Organizations sometimes say, I need to do a X number of millions of dollars of improvement. But boy, that is really going to be painful, and it's going to require downsizing, restructuring, reorganization. It's going to be very difficult to manage this with my medical staff, et cetera. And so what the tendency is to pull back on really what needs to be done. And what leaders have to understand is there are no secrets in organizations at any level. So when you're being disingenuous as a leader about your financial picture, about what has to be done, health employees are smart and physicians are smart. And what my suggestion would be is bite the big bullet and put it out there in front of all the employees and say, it's a $500 million improvement, it's $1 billion improvement, or whatever the size it is, and say, I know it's going to be hard, but I'm going to elicit your support to helping us get there. But don't try to bite it off in just small increments, because it destroys trust, it destroys engagement over time, so that you can't be innovative and you can't be transformational. Put it out there and do the right thing for the organization and show courageous leadership. Just put it out there and move forward with it. Because at the end of the day, when it's all said and done, your employees and your medical staff and your community will respect you for doing the right thing, even though it was very difficult to do.
Yeah, thank you. Reid?
I'll maybe answer this from a slightly different point of view, and Claire, which is to say, how do you keep people who are close to the work or at the front lines of the work engaged in moving really rapidly with innovation? One of the frame shifts that I think has been quite cool with COVID-19 is this explicit acknowledgement that we actually don't know exactly what the right answer or model or approach is. And so people have permission to try to figure that out, looking at the cycle and the routine of daily and weekly work. Innovation takes you got to be willing to take risk. It takes courage. It takes permission to be wrong. And it takes explicit permission for the people who are doing the work to then sort of rapidly adapt from what is happening. And in addition to that, I think it takes putting those people in a position to have not just an outcome-based return on innovation, so we can see that some clinical outcome or some business outcome improved, but also an emotional return on that investment, meaning I did something that was good and I had a positive emotion in shifting the system that gives me, pride or hope or interest or awe in the thing that we just did. And so I think keeping that space open, saying, there are a lot of things in healthcare, not just COVID-19, where we don't really know the right answer. And if we give people permission to take a risk, to rapidly adapt, to feel the emotional in addition to the measured business or clinical outcome ROI, that cycle will perpetuate itself. Historically, we've put all kinds of barriers in front of completion of that cycle. We have said, here are all the reasons you as an employee can't take a risk. Or here are all the ways in which you're going to get punished if your idea isn't perfectly right out of the gates. Or we'll measure the impact, but we're going to give you the impact measurement a year down the road, not tomorrow or next week. We just don't have an approach for talking about how did it feel to go from A to B? And do we need more B because it feels right and it's good and people are talking about it at an emotional level instead of purely a quantitative level? And what I think has been really interesting about a lot of the adaptations, the innovations in COVID is, as we sort of move from that old model to this current model of innovation, there was initial fretting about, well, how are we going to do on these important metrics that we're accountable for, like mortality and length of stay and cost of care. And in many cases, what's emerging is we're actually doing better at those things than we were doing before, because we allowed people to innovate at the front lines in the way that Clark and Jeff and Chuck are talking about.
And Reid, you bring up a good point, and I think it's something I'd ask you to think more about or share more about, I should say, is this idea of, if there is risk of stepping out and not being 100% right, then what can we do as leaders? What can we do to nurture that environment that we want to see?
Well, I'm going to go ahead and transition to some of the questions that we've gotten from our attendees.
Sorry, AC. That's always that's my favorite question. I know Reid's got good thoughts, but sorry.
So, but I think that's going to be addressed in some of these questions. So, and Jean has very nicely listed them all for us. The first one is, with the increasing political polarization we see in our country, what approaches might be critical in developing the trust that we've been talking about we need to have to collaborate? Anyone want to take that on and perhaps also address Jeff's inquiry as well?
Well, I'll start. And Claire, one of the lessons that I took from my design thinking training is, particularly in fields like medicine, and I think there are lots of other examples of this. So policy and politics is a great example. I see a lot of this in education. We do a lot of talk to try to get people to change their minds. And the design mindset is, what we need to do is do. So instead of talking about how we could create a better experience or a better tool, let's build one and put it in the hands of people and then let them tell us what that experience is like. And let's spend time together as human beings doing together more than just talking at each other. And I think that in some ways lies underneath the answer to that question about politicization. As long as we keep talking at each other, we're going to continue to find lots of reasons that we can't agree. COVID-19, if we take it back into healthcare, was this beautiful example of in several of the care organizations where I have done work, there was a pretty big divide, honestly, between the administrative leadership and the clinical workforce. And all of a sudden we said, we just got to do every day. We got to innovate every day. We got to solve problems every day. And we're suddenly doing so much to solve the problems together that it feels like we trust each other. Whereas a month ago, that wasn't the case. So I think that's part of the leadership practice as well. How can we bring people together? And Chuck had mentioned this. How do you gather your best and your brightest and put them to work doing instead of just having more and more retreats and conferences and opportunities for people to articulate their point of view more clearly, so that the other side, perchance, this time will actually understand why that point of view is as valid as I think it may be.
Mm-hmm. How about you, Chuck? Do you have a response to that as well?
Well, I agree with Reid's comments. The only thing I would add is on the political divide here in our country about how we approach like this pandemic and other issues, similar issues, reimbursement, healthcare, et cetera, is kind of going back to the data and let the data be a driver in the decision making and how we inform our decision makers about processes that we need, and just let it be data driven. To me, that's the most logical and makes sense way to do it.
Mm-hmm. Well, if you have data, then you've been doing, that's for sure.
Yeah, that's true.
Clark or Jeff, do you have any follow up on that?
I think it's a good point you make about letting them try, because as Clark and I are uncovering in a project that we're working on now, that the organization's innovation process is a pipe. And so people expect that whatever's dropped in the top comes out the bottom. And there's not enough of that critical questioning or yes-anding. But also what it does is it creates a lot of, knowing that there are very few places to influence a decision once it's in the pipe. It creates a lot of bickering at the top of the pipe. I don't want to call it debate, I'll call it bickering at the top of the pipe. And so as a result, we're working to make it a funnel. And what creates a funnel is this idea of yes and thinking. Clark, I don't know if you want to talk more about that.
Thanks, Jeff. The idea of yes and thinking is, and Jeff has a wonderful phrase about this, when you're in conversation with someone and they'll take what you've said and add the word but to it. I understand how you could make that work better, but, and then everything behind the but is erased and there's a new assertion filled in. Yes and is an additive way of thinking. It is improvisational, and it doesn't erase another person's point of view. I've only had one experience that's relevant to this conversation about closing the gap that I can quickly tell you about. Several years ago, I was part of an organization that was working on the idea of nuclear disarmament of the political arsenals around the world. And this was an American group. We decided to bring together all the stakeholders in the drama. So that was everybody from military contractors to the military to nonprofits, peaceniks, etc. The first meeting we had in a bucolic setting was a disaster because everybody came in their uniforms, literally. And when a peace person would see a general, boom, no communication would take place. The next time we met with a different group of people, we didn't put anybody's title, affiliation, and no one wore uniforms. And we spent the first day talking about our families. And we found an amazing amount of common ground. And on the third, last day of the retreat, we asked people to come in their uniforms. And it was an astounding, tear-invoking experience when a person running a nonprofit disarmament agency embraced a two-star general because they had found the human bonding in between. And that's an actual event, but if you can metaphorically apply that to the gaps, it teaches us that that communication and curiosity are the two forces that can begin to dissolve some pretty hardened positions.
Excellent, thank you. Let's go to our next question. We have, what do we need to do to use human-centered design to transform not just processes within the system, but the system itself? Jeff or Clark, do you want to start off with this?
Yeah, well, as they say, that system level change is a wicked problem because there's ambiguous inputs, there's conflicting interests, and the goal of the outcome isn't always clear. And we risk treating the wrong symptoms and actually making the underlying cause more damaging. And I spent a lot of time personally reflecting on, is it bottom up or top down? And I think it's both. I don't know, Clark, what's your opinion?
Oh, well, of course, I agree with what you're thinking, Jeff, and I won't add to it. I'll let others contribute. You said it well.
Reid or Chuck?
I would just say briefly, and Claire, that systems problems are, in my experience, precisely what user-centered design is best at tackling. When there's ambiguity, when there's emotion, when there's lack of total clarity or consensus about what to do, and when there's a need to change our point of view, that's what design and design thinking are really good at doing. And those things are necessary ingredients to change the system, not just to incrementally improve the process.
Thank you. Chuck?
Yeah, I think that finding solutions to things, to problems that have plagued us for many decades in healthcare, just involves listening to the people that are actually doing the work and letting them help be part of the plan design. And it takes again, we alluded to this earlier, it takes a lot of courage from leadership to do that, because leadership oftentimes feels that that's their role. But when you are being inclusive of everyone from the neurosurgeon to the environmental service person in the organization and everybody in between, saying, here is our problem. We need a model. We need a design remodeling of the problem. How are we going to tackle that? And really empower the workforce to help you get that done, and to be vulnerable and say, hey, we don't know, we don't have the solution here. We're coming to you to help us figure out a solution. And then acknowledge the individuals that are participating in that redesign or that new plan or new model of care or whatever, and put them out in front of the organization. It does so much for engagement. It does so much for trust. And you'll come up with a better model. You'll come up with a transformational model about what you're trying to change within the organization.
Thank you. Thank you all. So we were just about out of time. So I want to thank Chuck Stokes and Clark Kellogg, Jeff Eyet, and Reid Pierce for being our panelists today, and all of you for attending today. Jean, I'd like to just send it back to you for if there's any follow-up in terms of when the recording or any other kind of sort of logistical things that we all need to know about.
Sure, Anne Claire, thank you very much. The recording will be on the website certainly by the first of the week, and we will encourage you to continue tracking with the website for more of these kind of events, more of these kind of conversations, and many more discussions in terms of how do we translate everything that was said today into action that we can actually learn all together about how we can help people not hurt so much. So thank you, and Claire, and back to you in the panel.
Okay. All right, everybody. Appreciate everybody participating, and have a great weekend.
Great.
Have a great
Thanks, everyone.
Thanks very much.
Bye-bye.